Good afternoon, everybody. My name is Rachel Weisbrod. I lead clinical affairs at Medasense. I'm really delighted to welcome you to the first in our series of NOL Explore webinars. Thank you for taking time out of your busy schedules to join us today. In this series, we'll be focusing on the clinical implementation of NOL monitoring in routine practice in spinal, colorectal, and thoracic surgery. We will be looking at the clinical pain-related challenges in each surgery type and exploring how NOL can help address them. We'll also be hearing more about the process of introducing NOL into regular clinical use. Introducing new medical technology is a classic example of change management in clinical practice. Now, no patient monitor, as good as the technology might be, will improve patient outcomes by itself. Achieving consistent improvement depends actually on the level of clinical, implementation and adoption by the team. So today we're going to be hearing more about how NOL monitoring was integrated into routine practice at Carmel Hospital and helps enhance the collaboration between the different members of the surgical team to the benefit of patients. I'm delighted to introduce our speakers today. We have Dr. Ze'ev Goldik, Head of Anesthesia, Critical Care and Pain Service at Carmel Hospital, Haifa, Israel, and is also a past president of the ESA, the European Society of Anesthesia. In addition, we're absolutely thrilled to have Dr. Arsen Shpigelman with us. He's the chief of the spine surgery unit and a senior surgeon at Carmel Hospital, working with Dr. Goldik. We'll start with a brief introduction of personalized anesthesia and the role of NOL in this paradigm. It'll be followed by the anesthesiologist perspective on spine surgery from Dr. Goldik. Dr. Shpigelman will then share the surgeon's perspective on pain-related challenges in spine surgery and how NOL helps address them. Dr. Goldik will then summarize and we'll have some time for Q&A at the end. So please feel free to send us questions on the Zoom chat and we'll have 15 minutes at the end for Q&A. So keep the questions coming. Dr. Goldik, over to you.
Thank you very much, Rachel. I'm very happy and very pleased to be with you and with my colleagues from all over Europe and Latin America and Israel. Allow me to start saying that American sociologist in 1993 published his theory about Donaldization of the society. This theory says that many aspects are adapted from the characteristics of a fast food restaurant to other modalities in life. And as we know, anesthesia is our patients are not hamburgers, and anesthesia is not fast food. So we appreciate very much what is called personalized anesthesia. That means that our daily use of milligram per kilogram of our drugs in anesthesia is not a standardized way of life. And this is because there are many challenges when we use analgesics like opioids, for instance, because there is a very broad interpatient variability, and because there is a synergistic interaction between hypnosis and analgesia, and each component must be titrated individually, especially now that the opioid tolerance is getting more and more expanded. So maybe during all these years, we are using in anesthesia practice what is called the educated guess. We base our decisions in indirect parameters like blood pressure or heart rate, and we act accordingly to these very indirect parameters. And the result could be that we are using too much opioids or too little doses of opioids, with the consequent complications and problems like hypertension and severe postoperative pain if we underuse analgesics, or the opposite if we use excessive use of opioids. So we know that anesthesia is composed, the three main components of our doing anesthesia is analgesia, hypnosis, and muscle relaxation. And for muscle relaxation from the 70s, we have a monitor developed in Boston by Hassan Ali and his group, which is called Train of Four, stimulus of 2 hertz, consecutive stimulus, creating a movement at the adductor pollicis brevis, and then we can monitor our muscle relaxation and use of muscle relaxants during anesthesia. In the 90s, also in Boston, was developed the bispectral index as a monitor for hypnosis. And we know that from 40 to 60, around from 40 to 60 is the correct appropriate range of use of hypnotic drugs like propofol, for instance, in anesthesia. What is remaining is a monitor for analgesia. Maybe this is the missing link in monitor, and for this reason we are using these indirect parameters. We all know that we use the visual analog scale as a subjective index of pain, but this is in a conscious, awake patient. This is not appropriate to use. We cannot use it in an anesthetized patient. So is better and much more appropriate and possible to use nociception as a expression of pain in an unconscious patient, being nociception defined as an unconscious response to a harmful stimulus. This is what we would call pain in a conscious patient. So nociception activates the sympathetic nervous system, and we can recognize the complex nature of pain using the nociception level monitor, which is a unique multi-parameter based approach. Using a probe composed by 4 different sensors, we test during the operation temperature, peripheral temperature, photoplethysmograph, galvanic skin response, and accelerometer, being skin temperature a expression of vasoconstriction or vasodilation, galvanic skin response talking about the, for instance, sweating of the patient as an expression of nociception and pain, and the accelerometer presenting movement, and photoplethysmograph, which measures pulse rate variability, and photoplethysmographic amplitude. And I remember when I received in my hospital the first monitor for nociception, the NOL monitor. We use it at the delivery room, and we could see an excellent correlation between the contractions and pain of the lady, expressed in the visual analog scale as well, and the NOL level. You can see an excellent correlation between both. The clinical evidence of NOL monitor was demonstrated in many articles. Only as an example, I can mention this article published by the Albert de Haan group in the Netherlands, describing reduced postoperative pain when you use the nociception level guided monitor to guide use of fentanyl and sevoflurane during anesthesia. So I think that we found finally the missing link, which is a good monitor for analgesia that was absent in the previous year. You can see here, for instance, an example that in the at the bottom of the screen, you can see the level of 35 of NOL monitoring, telling us the patient has pain or nociception, high nociception. And at the upper monitor, you can see that there are still not changes, not in blood pressure and not in heart rate of this patient. So the NOL monitor is better than the indirect parameters identifying pain in this patient during anesthesia. As it comes to spinal surgery, so there are special challenges in these kind of operations. We have to assess carefully at the preoperative period airway of the patient because of possible deformations and difficult intubation, cardiovascular problems like pulmonary hypertension. It's very important, the consequences of the prone position of these patients. We have to try to avoid damage like visual loss or damage to peripheral nerves. And of course, position is also very important in maintenance of low venous pressure at the surgical site to avoid bleeding. In many of our patients, in neurophysiologic monitoring is used. A neurophysiologic monitoring consisting in the use of motor evoked potentials, somatosensory evoked potentials, electromyography. All of these are used to monitor spinal cord function during surgery. And the consequence is that we have to avoid use of inhalation anesthetics and neuromuscular blocking agents during this operation. So my colleague, Dr. Shpigelman, will explain why we decided to map all steps of the different operations, starting on operations like discectomy or laminectomy or spinal fusions, in order to find out what are the painful moments of this operation, the painful steps, and to accommodate, to adapt exactly the dose of the anesthetics during the operation, because, as I said before, automatic calculation of milligram per kilogram will not be appropriately sufficient to adapt our anesthesia. So I can say that 1 or 2 level decompressive procedure, a short procedure, low dose opioid along with other analgesics would be appropriate to use for this kind of operation. And on the opposite, for multi-level spine surgery, a multimodal approach for pain control would be necessary. We all know the ERAS protocol, which is an enhanced recovery after surgery protocol. We know that NOL, I am convinced that NOL monitor can benefit, can be very efficient for us to reduce the dose of opioids, unnecessary high doses of opioids, shortening the length of stay of this patient. ERAS is a multidisciplinary approach, and for this reason, we decided with our colleagues, the orthopedic surgeons, to do it together and to monitor together, conducting the operation in a scientific way. At next session on Thursday by Professor Dan Longrois, he will explain the algorithms we have when we use NOL. We can use a perfect algorithm For instance, when the patient has high blood pressure and high heart rate, we look at the BIS monitor and we look at the NOL monitor and we act accordingly. Because, for instance, if the patient has high blood pressure, analgesic is not the treatment. Analgesic is a treatment for pain and not for high blood pressure. And NOL helped us to make the correct diagnosis what is happening with nociception of this patient, and also at the opposite situation when the patient has low blood pressure, how we have to act. We are interested in this special protocol of opioid-free anesthesia that we decided that is also appropriate for spinal surgery, and NOL helps us a lot to manage the analgesic treatment of this patient. And according to NOL, we know what is expected and how we have to continue with the calculating the dose, appropriate dose for this patient according to the BIS monitor and according to other parameters. So it's important to say that the NOL monitor is very, very efficient, but more efficient than that is the combination. The combination of all this monitoring together that give us the whole range of all aspects of the main components of anesthesia, which are analgesia, hypnosis, and muscle relaxation. And then we can tailor a personalized anesthesia management for our patient using the exact dose for all these drugs and conducting in a very appropriate way anesthesia and giving to our patients a rapid recovery. So we integrated the use of NOL as a vital monitor in daily use of in our operations. Thank you very much. Now I will give the floor to my colleague, Dr. Arsen Shpigelman, please.
Yeah, thank you very much, Dr. Goldik. You know, probably I'll change just a screen view to my one. Yeah. Okay. Good afternoon to all. Thank you very much. And it's really my pleasure to be the part of this, I think, this great and a new challenge that we have a possibility to use in our hospital. And for sure, one of the most important law in orthopedic, I think, and the surgery as well, that the plan the operation and after there operate the plan. But I think in our profession, the plan the operation is together with other professionals. And in our case, this is together with the anesthesiologist as well. That's why we're starting with the NOL monitoring in our department and in my unit during the spinal surgery. No pain, no gain. This is a really famous sentence, but for us as surgeons, this is our motto. But for our patients, I think that's our fault, because patient without pain, that's our success. Spine surgery is one of the most successful surgeries performed in the world. It has undergone massive advancements since last century, and I think we started last century as a simple procedure than the spine surgery. As Voltaire said, he who doesn't know the past doesn't know either the present or the future or himself. About the spinal surgery, we know since Smith papyrus from Egyptian mummies in 3000 BC, we have an evidence of the spinal surgery, as well as in the Hippocrates papyruses as well. We have additional information about the cases of scoliosis, fractures of the spine, sciatic pain, and the dislocation of the vertebrae. First laminectomy was checked around the 650 AD. Throughout history, surgeons all over the world contributed their skills and knowledge just to develop ways to perform spine surgery with the least amount of pain for the patient. And today we have all the kinds of the techniques like nucleoplasty, minimal invasive surgery, endoscopic spinal surgery, and it's widely known just as a standardization of the invasive technique to have a shorter recovery periods after the surgery and just to reduce the pain after the spine surgery. Pain is the most important criteria to decide a spine surgery performing. And we know now what the Voltaire said, and now we know the past. We make the present, and for sure, we want to improve the future. What's the pain? Pain is unpleasant emotional and sensory experience associated with potential injury of and damage of the soft tissue. And I think any surgery, there's for sure damage for the tissue. And during the spine surgery, my opinion, the surgeon is a pain producer and the anesthesiologist is a pain reducer. Range in complexity from minimal invasive endoscopic surgery, a single level discectomy, decompression, and to the highly complex multi-level surgery done in our department. Statistically, under the 60 years old, that's a disc problem, like a disc herniation, and over the 60 years old, there's a degenerative spine diseases and a spinal stenosis. We use NOL monitoring for all thoracolumbar spine surgeries. We divide all spine surgeries in 3 main groups. First, that's discectomies or minimal invasive procedures. The second one, that's laminectomies and decompression. And the third one, there's all the groups with implants like vertebral fusions or fixation. Operative technique was standardized in our unit and step by step for each procedure. Together with the anesthesiologist, we composed the protocol for any intervention just to check the NOL measurement during the surgery. We can identify the most painful step in each procedure. We can see here this is a protocol for discectomy or minimal invasive surgery since skin cutting and a subcutaneous tissue cutting and until the skin closure. And we can check the timing of the procedure, null data, and by the anesthesiologist as well, anesthetic and analgesic quantity. As well, this is a protocol for laminectomy or decompression surgery, as well starting with the skin cutting and until the skin closure, with the checking of the timing of the procedure and the null data as well. And for sure, much bigger protocol, this is for fusion or implantation, and for sure for multi-level procedures. We have in the soft tissue cutting, and after the laminar preparation, as well as disc preparation, screws insertion, and disc space preparation and cage insertion until the skin closure. For sure, the same, we check the timing of the procedure and the NOL data in step by step in each procedure. Just the same case, this old 71 years old lady, the spinal fusion in the thoracolumbar spine was done, and we see here on the graph some peaks of the during the procedure, and after the procedure we reassessed that was the peaks of the screws and cages insertion. And here, that is another graph. We can see the two peaks more than 50 by NOL with the cages insertion in interbody fusion, and much lesser during the disc preparation. Here, and here we just prepare the disc to put the cage between the vertebrae. That's why NOL monitoring we're using to prevent an opioid and other analgesic agents overdose, and for sure for adequate pain control during the spine surgery. As a result, why we need it? Because the main point, that's not only a surgery, but the result of the surgery, the procedure. We need an early, and we can to do an early postoperative patient's neurological status checkup immediately after the surgery. Due to preventing opioids overdosing, we have a possibility for early postoperative mobilization of the patient, as well as easier postoperative pain control. And due to early mobilization and pain control, we have a shorter hospitalization period in our department. That's why no pain, no gain. This is for sure our motto, but we need to prevent the pain for our patients. Thank you very much. Okay.
Okay, so if we want to say a sentence summarizing, I think that the balanced and most appropriate monitor to use during our anesthesia procedures, during surgery, is a perfect combination between the train of 4 or neuromuscular monitoring, between bispectral index in some cases, and between NOL, which must be integrated according to our opinion to daily practice in anesthesia in order to follow up the nociception levels and pain of the patient during the operation. Thank you very much, and we are open for questions.
Thank you very much, Dr. Goldik and Dr. Shpigelman. And yes, we are beginning to see the questions coming in. Let me kick it off here. The first question is about postoperative pain. So in your experience, is NOL informative about postoperative pain?
Of course, we read some papers published about the relationship between a good management of surgical pain during the operation and its relationship with postoperative pain. And when we control adequately pain and nociception during the operation, we are also avoiding postoperative pain after the operation. This was demonstrated, and the early recovery of our patients. Yes.
Yeah, I think so. You are quite right, because for sure we just see the much better results during the last time after the surgery with the postoperative pain, because during the great intraoperative pain control, we have much more possibility just to recheck the pain after the surgery, and recovery, it's much easier for our patients.
Another question for you here, Dr. Shpigelman. I wonder whether there is a correlation between the use of NOL and rapid neurological assessment after spinal surgery. You touched upon that, but perhaps you could explain it in a little more detail.
Yeah, okay. For sure, one of the most important point of the spine surgery, this improvement or rechecked neurological status after the surgery. Usually, we just saw that the patients wake up after the surgery before the NOL experience. The wake up was much longer due to, I understand now, due to overuse opioids or other agents during the surgery. And now we have an experience during the NOL monitoring. We have a possibility to check up a neurological status of the patient immediately after the surgery, because surgery just leave an operating room to the postoperative room in the just wait. And that's why we have a great opportunity to check a neurological status closely to the operation.
Thank you for that. Now we have a question here, I think, for Dr. Goldik. This is about ERAS. So thinking about ERAS, we use non-hormonal anti-inflammatory drugs. Did they interfere with the NOL reading? So do non-opioid drugs or other drugs interfere with NOL in your experience?
They don't interfere, and of course, NOL is minded to be used in anesthetized patients, but rapid recovery after the operation and use of anti-inflammatory drugs at the postoperative period, it doesn't interfere. Of course, it helps a lot, and the reason why I could see a question about one of our colleagues here in chat regarding the case I presented, and Dr. Shpigelman presented as well, where the patient had most of the time less than 25, but it also had a low level of nociception. This kind of overuse of the anesthetic drugs or painkillers during anesthesia, that was the reason why we decided to map better the use of analgesic drugs during these operations, because the obvious complication of using a neurophysiologic monitor, and then you are very much limited in use of other drugs like muscle relaxants or inhalation anesthetic. So you tend to overuse the analgesics. And then that was the reason why we decided to map better the different steps of these kind of operations in order to avoid overuse of these analgesic drugs.
You are quite right, and this is regarding the next question, just about the multi-level fusion. And the question is if especially the patient with multi-level fusions will benefit from NOL. Yes, for sure. As Dr. Goldik said, we just saw this, I just remember this case, it was a 3 or 4 level fusion just with insertion of interbody cages. And after the surgery, we saw that the graph of the NOL was with some peaks, and by the time we saw that each of the peak was during the cage insertion. And that's why we saw that it's really interesting to map our surgery, to check step by step any spinal procedure, and to check what's the NOL monitoring for each step. That's why we started with that. And now we know if we are going to do some multi-level procedure, and very important, anesthesiologists know as well that the screw insertion is painful, and the cage insertion is much pain. The patients suffer much more pain than in the soft tissue procedure or during the skin cutting as well. And this is a headache of the anesthesiologist, that he needs to do or to give more opioids or more analgesics during this step. That's why we are using the NOL exactly in our during our procedures, as well in the multi-level fusions.
And I do think that this study that you are conducting now, where you are objectively quantifying the level of nociception in various surgical stimuli that are typical to spine surgery, will be of great interest to the clinical community, because to my understanding, this is really something that isn't established. And at the moment, it's estimations, but not any objective measurement. So it'll be really interesting to see when you complete the study. I think it's an important piece of work.
Thank you. I can see here two questions from our colleague, Julian Raft. The first question is about cost. How can we justify the cost in even in short operations, spine operations, that we have to use the different the sensor that we have to change. In my department, when we are using drugs like Sugamadex, dexmedetomidine, or when we have to use things that the cost is higher, I always explain to the management of my hospital that the overall cost of all anesthetic agents we are using, together with the anesthetic monitors and all the stuff related to anesthesia, is 5% of the cost of the total cost of the operation. So if we want to spare money from our and to lower the costs, this is very important, but we have to take in consideration that the cost-benefit effect is more important. And if the overall cost of anesthesia is 5% of the operation, and my colleagues, the surgeon, are using all these very expensive staplers and other stuff during the operation, I think we can allow ourselves to use an important monitor, even if we have to change the sensor. And the second question of my colleague Julian Raft regarding NOL index and opioid-free anesthesia, this is one of our next works and researches we are going to do for spine surgery. We already tried the opioid-free anesthesia for bariatric surgery and other using NOL and other operations. And we demonstrated that opioid-free anesthesia is very appropriate. You can manage appropriately analgesia of this patient using opioid-free anesthesia, but NOL, of course, can be very, very effective in conducting and guiding your anesthetic management during the operation.
There is another question here, which I think is interesting, concerning the parameters that you react to first. Do you react first to BIS or NOL when working according to your anesthesia algorithm?
Well, this is the art of personalizing anesthesia. So the correct combination between both of them, if I think it will be very well explained by Professor Dan Longrois on Thursday when he will present the algorithms. But you consider all the parameters together, the indirect parameters like high blood pressure or heart rate, together with BIS, together. Obviously, when a heart rate and blood pressure are high and the BIS is high and NOL is high, it's very easy. You can know that anesthesia is very superficial. You have to dip the hypnosis and to dip the NOL. If the blood pressure didn't react and you can see that NOL is sustainedly high, you react using the analgesics. But in case we are using muscle relaxants, if we want to avoid awareness of the patient, is not enough to give fentanyl or remifentanil. There are many reports of awareness because the patient can report that the patient is not sleeping enough, is not an adequate level of hypnosis. So we use all these combinations. I don't think there is a magic answer. What is what you do first, BIS or NOL? I think BIS is still not a standard monitor for hypnosis alone, but using BIS together with NOL in combination, I think they potentiate enough both monitors, and they allow us to take good decisions during the operation.
Thank you. I have another question for you here. We know that this is actually a question for both of you. We know that the typical patients who require spine surgery have been suffering from pain for a long time before they actually are eligible for surgery and their surgery is actually scheduled. So these patients could also be defined as suffering from chronic pain, and some of them may have been using opioids prior to surgery. Is NOL helpful for you with these type of patients?
Arsen, do you want to answer to this question? Because you all the time you can see these chronic treated patients for pain.
Yeah. First of all, I might have to say that the spinal surgery just couldn't treat and couldn't, for sure, I think, couldn't treat completely and drug dependers and the drug abusers. But on the other hand, the long period of the opioid treatment before the surgery, we are starting just to explain to our patients in the clinics before the surgery that they must to reduce dosage and opioid treatments as well. But on the other hand, during the surgery and thanks to the NOL monitoring, we can see that we started to use much less opioids during the procedures. And during the surgery, our patients, we are using less opioids, and after the surgery, we just get it out, the spinal problem. That's why I think we can to prevent or to improve the status of the opioid overuse before the surgery. I think this another question and another program to check each patient, how long period of time that they had an opioids using before the surgery and what type of opioids as well. But I think it's a really important part of this program.
Okay. How did you find the clinical implementation? You're already obviously experienced with the use of all the standard of care monitors. I'm just wondering if you could share how it was for the team to go through this process of change management and to start using a new technology and integrate it into routine practice. Was it hard? Was it less difficult than expected? What were the factors that made it a success?
I have to say that this is a very, very friendly monitor, very simple, and it helps a lot. Keeping simple the treatment of the patient and the use of different drugs. Our young anesthesiologists are very much enthusiastic about the use of this monitor, because technology helps a lot in anesthesia, and we all the time we compare anesthesia with the flight, and we want to monitor and to pilot all the time the management of anesthesia. It was very easy introducing this monitor. I can see here a couple of questions related to the awake patients. So I have to say that NOL monitor is still not validated for using it in awake patients. Obviously, in awake patients, we can use the visual analog scale, and this patient can tell us that they have pain. So it's easier. So in case of awake patients or very light sedation, still the monitor is not validated. I know that the developer of this monitor they have plans how to integrate special algorithms for awake patient, isn't it, Rachel?
Yes, this is correct. This is part of our vision, and we are conducting some initial research in awake patients. We have several studies going on. And as to the question about whether all 4 parameters should be used all the time, the answer is yes.
Yes, they are. It's an algorithm integrating all these 4 parameters. That doesn't mean that you have to see the 4 parameters at the screen. You can calibrate the screen in such way that you can only see 1 or 2 of these parameters, but the monitor is integrating all of them during the whole time. And regarding the question of our colleague Anna Paola, does NOL need to be calibrated before induction of anesthesia? Yes, the answer is yes. We connect the monitor and we give time for the monitor to calibrate himself, because this monitor is adapting the measurement for this specific patient. And the baseline is important for this algorithm to consider what is the correct range for this patient during the operation.
We also have another question here about the use of NOL in the ICU in mechanically ventilated patients who are typically deeply sedated, and they're receiving continuous infusions of sedatives and opioids. So perhaps Dr. Goldik, you would like to comment on that?
Yes, in one of the hospitals in our country, NOL was used during the COVID treatment, the treatment of the COVID patients. And because these patients, as we know, the COVID-19 patients, you have to use a lot of sedation and analgesic drugs during the prolonged period. And if we want to avoid delirium, cognitive dysfunction, and we want to do a good weaning of these patients from ventilation, in one of our hospitals, it was used, and they demonstrated a 25 to 30% sparing of analgesic drugs like remifentanil or dexmedetomidine during the treatment of this patient in ICU. In our ICU, in our hospital, we used it in a very, very successful way in order to wean from ventilator a patient that was connected to ECMO for a very long period. This patient it was one of the successful treatments by ECMO and prolonged ventilation in our hospital. And we are sure that connecting him to NOL helped us a lot to conduct in a better way weaning from ventilation and from ECMO. Curiously, we could see that influence in the NOL level when a relative of this patient started talking to this patient, and the excitation of the patient, and we could see the change in the NOL values during the treatment of this patient under tranquilizers, under analgesic drugs, and and connected to ECMO before the weaning.
Thank you. There is a question here about the effect of poor fluid management, so I will quickly answer that. What would happen to the NOL measurements? So in order for the NOL to work correctly, we need to have a patient with good perfusion so that we can get a good PPG signal. If the patient is poorly perfused, that this could affect the signal quality that we acquire using the finger probe. So, of course, the patient needs to be adequately perfused in order to be able to get a good signal, which is essential for them to obtain the robust NOL readings. There is a final question here just before we wrap up about the advantages of NOL compared to other monitors. I assume that the question is referring to other nociception monitors. Any comments on that?
Well, when I had to explain to the management of our hospital why I choose this specific nociception monitor after I tried another one, for instance, you have the limitation with other monitors using analysis of electrocardiogram and pulse variability only, that you have to use the electrodes in different parts of the body. You don't want to interfere with the operation. So I think this nociception monitor, the NOL monitor, is better integrating many modalities together, and the reaction of the patient is much more integrating all the aspects of nociception. This is why I think that it has advantages compared with other kind of monitors.
Thank you. We have a final question here because we are out of time. Can I start to use NOL in the middle of the surgery? Well, technically, of course, this is possible, but definitely not recommended. We recommend using NOL from the beginning of the surgery. after induction until the end of the surgery, so that we can review the trends, because this is really what is important to inform clinical judgment, looking at the trends and not looking at just one specific point in time in isolation. So with that, I'd like to bring this event to a close. I'd like to thank our speakers again, Dr. Goldik and Dr. Shpigelman. Thank you very much for great presentations and your insightful comments and responses to the questions, and look forward to engaging with all the audience. Thank you for joining us, and please feel free to reach out with any feedback or suggestions to us or to the Medtronic team in your region, and we look forward to continuing this journey together. Have a great rest of your day, and thank you very much.